Okay, hello everyone. I am so happy to be here with you tonight. I am Dr. Maureen O'Keefe from Purple Mountain Physical Therapy. We are in Grand Rapids, Michigan, and we specialize in pelvic conditions and neck and TM joint problems. And I'm really grateful for our speaker tonight. She recently had a baby and is generously donating her time. Maybe she's a little sleep deprived. This is Sarah Yskes. She is a nurse practitioner and she has special training in fertility and female hormones. And I can tell this is a hot topic because we had a lot of people sign up to join us tonight and who are asking also for the recording and a lot of questions submitted. So we will do our best to get through all of your questions, and feel free in the chat to post your questions, and we're happy to be conversational with you and try to get anything covered that is of importance to you. So Sarah, how about if you tell us how you got an interest in hormones, menstrual cycle, because in her practice, she treats all ages, adolescents and adults. She does treat men, boys, but she specializes in girls and women as well. So what spurred your interest in this, and what advanced training did you pursue for it?
Yes, so I mostly got an interest in it during my clinical rotations for NP school. One of my clinical preceptors had just recently completed a FEMM medical provider training. FEMM stands for fertility education and medical management, and that is the training that I went through as well. So she was really getting into it with her patients when I was doing a rotation with her. So that's when I got introduced to it, and I kind of got to learn a little bit along with her, which was really fun. And
so what did that involve? So fertility education, menstruation, and what was the last M?
Fertility education and medical management.
Oh, medical management.
Mm-hmm. And so that kind of is like the two main branches. So there's a lot of educators for fertility, like not just necessarily how to achieve or avoid pregnancy, but are you fertile? Do you ovulate? Is your body healthy in that way? And if you have questions, concerns, then you go to the medical management part of it, where it's hormone testing, looking at kind of what's going on and how to treat it.
And you're doing that all the time?
Yes.
Every day. Yeah.
Yes.
She has a very busy caseload, and your clinic is in Kalamazoo?
Yep. So we have one office in Kalamazoo and one in Hartford, which is sort of near South Haven. Yep. Hartford's our main office, but we get a lot of women's health at the Kalamazoo location, and we do some telehealth as well.
Okay, great. So can you explain to us a little bit about the normal menstrual cycle? I think a lot of us are like, what is supposed to be going on and what would be considered normal? So what is a normal cycle, and maybe go through the stages of the cycle and the different phases and what should be happening in our body?
Okay. So with a normal cycle, starting in puberty, you might have a year or so of irregularity, which can be normal. But a typical cycle for a couple of years after puberty and until the perimenopausal time is usually like 21, 24 to 35 days is a good cycle. And it should be regular, kind of like plus or minus 1 or 2 days. So if you have like a 32-day cycle, it should be 1 to 2 days on either side of that 32 cycle all the time. If sometimes you are like at 22 days and sometimes you're at 34, that's not normal either. So we're looking for regularity in that 21 to 35 day range.
That is huge. I have women tell me all the time, like, oh, I'm always going 34 days. Is that too long? And the answer would be that is within the normal limits, but you also may want to look at other signs and symptoms that you have that we'll talk about today to see if maybe you're not ovulating or you are having issues. But right off the bat, 21 to 35 days, you said, is normal.
That's the most generous limit of normal.
Okay, that's helpful. And then the other thing you said that is interesting is once a young lady gets her first menstrual cycle, you said within the first 2 years, it's okay for it to be a little bit wonky, right? So maybe at that point, we're waiting for her body to just try to figure out that its rhythm.
Yes. Now, if they're like really, really severe symptoms, then we would probably want to look into that anyway. Like if she's not functioning, missing school, ibuprofen's not cutting it, stuff like that.
Okay, yep.
But we expect some irregularity, not always to ovulate, those first years.
In those first couple of years. And when you're talking about missing a lot of school and things like that, we specialize in treating individuals who have endometriosis, and some people experience terrible cramping and pain from their first menstrual cycle, and they are missing school and they are having a lot of troubles. And that's the type of thing where we could partner with them, with your physician, to find out what might be going on. I'm not saying that everybody who has bad periods has endometriosis, but I'm pointing out that it can be something that is present even in these young ladies.
And frequently it takes a long time to diagnose.
It does. It takes a really long time to diagnose. Okay, so the normal cycle, 21 to 35 days long. And within that cycle, what are the different phases and what's happening in your brain, pituitary, ovary, all of that?
Yeah. So kind of the basics of the menstrual cycle is the follicular phase and the luteal phase. So the first part, the follicular phase, is kind of variable in length. And luteal phase, which is after ovulation, is about 2 weeks. And that's usually pretty consistent if you're ovulating. If you're not ovulating, you don't have a luteal phase. So those are kind of the two basic phases. The menstrual cycle, the period, is the first part of the follicular phase. So day 1 of the period, the first day of like light or heavy or medium bleeding, day 1 of the cycle. Period should be about 3 to 7 days long with at least 1 day of medium to heavy bleeding.
That's important to know, at least 1 day of medium to heavy bleeding, because you need to have enough endometrial lining when and if the day comes that you would like to have a child. You need to have a thick enough lining to have implantation. So pay attention to what your blood loss is. If you're not having a day or 2 in there with somewhat heavy flow, then you may not be building enough lining. Is that true? Okay.
Yep. So you need enough lining. Sometimes if you have like a really, really heavy period, you might have too much lining, too much estrogen. But
right.
That's
like, one of the questions that we will get to. Okay. So for the follicular stage, what is going on in the brain and the body to generate that? And that's our estrogen. That's the part of our phase of our whole cycle when we're more estrogen dominant, or estrogen should be the predominant thing going on. So can you explain that?
Yes. So the brain is producing FSH, follicular stimulating hormone. It's a hormone that goes to your ovaries to stimulate follicles to grow, hence follicular stimulating hormone. And as that egg grows and grows in the ovary, it'll produce estrogen. So yes, estrogen definitely dominant at that point. And it kind of goes right up to ovulation when estrogen really spikes, and that'll trigger another hormone, luteinizing hormone, to really cause that egg to ovulate.
That's helpful. So we're talking about some aspects of that phase are occurring in your brain and in your ovary. And that FSH hormone, for anyone who would experience infertility, we're all familiar, myself included, with getting measured to see if you have elevated FSH, and you're told that that is not good. But I can tell you from personal experience, if you do have that, you can reverse elevated FSH. There's so much you can do with lifestyle. And I did a whole program. I had infertility and so many troubles having children, and I did a complete holistic program. I learned everything she's talking about in that program, and it helps me even to this day, because it helps me with my patients and it helps me understand my own system. So in the first cycle, you have your follicular phase. You need to have follicle stimulating hormone at an adequate level to stimulate the follicle in the ovary so that particular follicle can develop. Then once we go into luteinizing hormone or luteal phase, we're shifting to another end of things. So what happens in the second half of your cycle after you've ovulated or with ovulation?
Yes. So after you've ovulated, going to that second part of the cycle. And so the egg's out of the follicle, and the follicle that remains after the egg is left turns into something called the corpus luteum, which stays in the ovary after the egg has traveled out, and it secretes progesterone. Now, the purpose of this in the body is to help maintain the uterine lining so that if there is a pregnancy, it can be maintained and nourished. But of course, the progesterone that's produced has amazing other benefits in the body besides just potentially maintaining a pregnancy. And then, but if there is no pregnancy, that corpus luteum really only can live for up to like 16 days, and then it'll shrivel up and go away, and then your uterine lining will shed. And period happens, and that starts the next cycle.
Okay. So that was very helpful. Thank you. I want to shift to some of the questions that were submitted. So one of the things that somebody asked was, what would you recommend are the best ways to understand your hormone levels in your body? And well, let's just start with there. If we want to track our hormones either at home or with a physician, first, can we talk about what a person can do at home to get a sense of where their hormones are at?
Yes.
And then maybe what they would do with a provider like you.
Yeah. So definitely helpful to chart your cycles. There are many apps. A lot of them are free. Some you have to pay for. Since I'm trained through FEMM, I like the FEMM app.
So that's FEMM. They have an app. They also have educational information on their website, don't they?
Yes.
Yeah, I went to it because in preparation for this. So it might be a nice resource for you.
It's nice. It's femmhealth.org.
All right.
It's a good one.
So at home, you would say chart your cycles just in terms of managing how many days apart they are, right? And what else?
And how
is
many
the charting
days of bleeding. So it goes through a lot of things. So it goes through like the fluids. So you chart your period, how many days you bleed, how heavy it is. You can also chart other discharges. So when around ovulation, when estrogen is high, your cervix will secrete estrogenic type mucus. So it looks kind of like an egg white. It's clear, it's slippery, it's pretty stretchy. And that's a very helpful telltale sign, that fertile mucus, that you will ovulate.
Yeah. That's very helpful. So for any young ladies who might be listening to this, in the middle of your cycle, if you're ovulating, you are going to produce this fertile mucus that is egg whitey, and you kind of go to wipe and it can be slippery.
Yes.
And I'm sure FEMM teaches you a little bit more than monitoring it that way, right? Like we did the whole, see how long it stretches and everything.
Yes, touching it, stretching it sounds pretty gross at first, hearing it, but
yeah, but at no
helpful.
cost, and it helps you know what's going on down there. Like we need to know this stuff. Okay.
Yeah.
And then what else can they do at home? What about temperature?
They can do temperature. I just want a quick note that sometimes some women do have like a physiologic vaginal discharge that's not like the stretchy mucus, but you might see like a little white pasty discharge. So that can be normal throughout the cycle as well, as long as it's not smelling bad or itchy or anything. But other things that you can monitor at home for free: basal body temperature. So if you get like a thermometer, they have them at Meyer, that's 2 digits. Those are nice. Just taking your temperature under your tongue first thing in the morning before you get out of bed at a consistent time. So it doesn't work. I used to work night shift at the hospital. It didn't work very well when you're flipping your sleep schedule all around. But if you have a consistent sleep schedule, it works really well, because you'll have a temperature rise after you ovulate. So if you're checking your temperature every morning, and you say, oh, my temperature is higher now, and it sustains it, and then it starts to decrease, and then you have a period, you know, okay, I've ovulated, because the temperature goes up with progesterone.
Yeah. So I measured my temperature for months. I mean, when you're trying to have a baby, that's what you do. I mean, a long time, way more than 12 months. And you can definitely get to know like, oh, okay, yeah, I ovulated already. So the temperature is a nice way of looking at things. I think we had a question. No, we didn't. Somebody, I think one of my patients asked me, what would you consider to be normal temperatures or temperature fluctuations? Do you have a number to put on that, or you consider most things to be normal and you would have to look at each person's clinical picture?
Yeah, because everyone will have a slightly different baseline of a normal temperature. You're just looking for a consistent rise.
I like that. So she doesn't give you like a flat out cutoff of something that's bad. So whatever your normal is could be normal for you. That's
Someone
great.
had asked like about a really low temperature on there, I think.
Yep. Yeah, the question that was submitted was that for this person, body temperature was not a thing she had ever thought about. And she's wondering if she has too low body temperature. And she would like to hear Oh, no, that was it. If she has too low body temperature, I know that sometimes can indicate thyroid issues.
That was
Is that
my
what you
main
come
thought
to?
as well. Like a hypothyroidism, maybe.
Okay, yeah. So do you work with hypothyroidism,
Yes.
and is there blood work that you suggest they have?
Yep. So I check the thyroid as part of the hormone panel of blood work that I check for menstrual health, ovarian health. Yeah.
Okay. So then when you said you gave us an idea of things you can look at for free at home to understand a little bit of your cycle. And then what are some of the things you could work at with a physician? Now or a provider. You already said a thyroid panel is something that should be looked at for all of us. Can you explain that and what the panel includes? Because thyroid problems seem to be ubiquitous.
Yeah.
You're probably discovering them all the time.
Yes, I mostly discover insulin resistance, but a lot of thyroid as well.
We'll talk about insulin resistance because
Yes.
that's a hormone too.
Yes.
Okay, so tell us about the thyroid panel and what you're looking for in that panel, and then the other things that you run.
Yes. So if people come to me with period problems, I'll typically run a whole panel. Definitely thyroid's in there. TSH is in there. Looking at how the thyroid gland reacts to that. So, and then looking at the hormones that the thyroid itself produces, T3 and T4. I also check thyroid antibodies, TPO and antithyroglobulin, just to see, hey, is there any sort of autoimmune component to any thyroid disease that could be contributing to this?
I have a ton of friends and people I know who do have that. And they have been able to improve that through lifestyle.
Yes.
You can. So if you have that, if you're experiencing any thyroid issue, my experience working with patients who have really tried lifestyle changes and personal people in my life, it is something that is modifiable. And you think so too?
Oh, I definitely think so. Yeah.
Isn't that great?
Almost everyone could have improvements in diet and exercise and sleep and stress.
Yeah.
Stress is huge. That's
it is.
Yeah, one of the biggest issues I see.
Okay, so you run a thyroid panel. What else do you run?
I run a lot of androgens, so free and total testosterone, androstenedione, DHEA, sulfate, it's either 17-hydroxyprogesterone. And then I do other labs too. I do prolactin, I do a fasting insulin, FSH, estradiol, which is the main estrogen and the most potent estrogen.
Okay. Let's talk about the free and total testosterone, because do you treat for that or are you, any treatment is just based on symptoms? If someone doesn't have symptoms and they don't need treatment for that, or what's the role of the blood test results of the testosterone?
Right. Usually if I run it, it's because there's issues.
Okay.
So then I would treat it. But I mean, you don't want someone to have too high of a testosterone. So I would, if it's really high, I would still treat it. Now, FEMM, and so then I have a little more stringent lab results than most typical labs. So you might see on your lab result yourself like, oh, this looks like it's within the range of normal, but according to us, it might not be.
That is helpful. Many of the lab results that are considered normal are too broad. They are not normal for you. So you could be told that your thyroid stimulated hormone is totally normal. It's between 0 and 4, but you feel crummy. That's because your normal needs to be down at like 2.5 or something, right?
Yes. For women of reproductive age, it should be 2.5 or less.
So you're saying through FEMM and the FEMM focus on female hormones, fertility, they have identified a more narrow range of what would be considered acceptable for all of these labs?
Yes. So they looked at women who ovulated. So they were healthy enough to ovulate, and then they made their range of normal based on that. So they didn't do an average of the general population. They looked at what was normal for healthy ovulating women. And it was a lot more stringent than the national average.
That is huge. Okay. I would like to go to her because you're always told everything's normal and you're like, is it really?
No.
Okay, so that was the free and total testosterone. And then the DHEA. Well, first I want to say testosterone. We have tons of testosterone like receptors in our body. It's really important for us women. We don't think of it that way, but it is something that is an important part of our lives. going to the DHEA, what is that hormone and how is that important for us?
Yes, DHEA. I can never pronounce what it stands for. So
Yeah, it's a lengthy one, but
yes,
everybody
it
just
is.
calls it DHEA.
So I actually typically run DHEA sulfate. They're similar but a little different. DHEA sulfate is actually mostly produced by the adrenal glands, while as DHEA is kind of ovaries and adrenals a
Oh,
little more
okay.
evenly.
Uh-huh.
So a lot of times when people are super stressed, their testosterone might be normal, but their adrenal glands might be on overdrive. So you'll see
For sure.
the DHEAS really high.
Yeah, okay. So if it
So-
comes high, then you're probably talking to them about lifestyle factors that they can do.
A lot of stress reduction, lifestyle, reduce caffeine, get enough sleep, anti-inflammatory diets and things like that. Medications too.
Yeah,
I do some medications for that, like a low dose dexamethasone if people are interested.
okay. And that would just be for a short period of time?
Yep,
And
just
it try to get the body
calm
calmed?
things down, helps it reset, and then you can go off of it and just, yeah.
Oh, that's
start
nice.
it.
Okay. And then the prolactin, can we talk about that one? Or I don't know much about that one.
That's the one that's typically thought of with breastfeeding and nursing. It's very high, helps with the breastfeeding. Can be elevated in a couple of different other ways too if you're not nursing. So it can be elevated with thyroid issues. It's produced by the same gland that produces TSH, which stimulates the thyroid. So sometimes a thyroid issue and a prolactin issue can go hand in hand, or one could actually cover up the other's issue. That will suppress ovulation. And you can kind of remember that because when you're breastfeeding, you're not as fertile, and breastfeeding suppresses ovulation. So that's also increased a lot with stress, both mental stress and also stress in the body, too much exercise, things like that.
So stress keeps coming up. We will get to some of these lifestyle things. Yeah. And so I have had patients that are not pregnant, not ovulating. They don't have babies. They're not breastfeeding. I shouldn't say they're not ovulating. They probably are ovulating, but they are leaking milk. So they'll have like a 7-year-old child and suddenly they're like, oh my gosh, I thought I was sweaty, but I was leaking milk. That person or those types of situations would make me think the prolactin, right?
Yes. And I mean, there are some situations where there's like a tumor in the brain that's secreting prolactin, which is causing that. And that's not common. Don't want to freak anybody out.
Very
but
rare.
Like, if you have milk leaking, definitely get it checked out.
Okay. And then let's talk about the fasting insulin, because you said this is the most common hormone in the panel that you find off. Probably this and the thyroid stuff, right?
And the androgen.
Oh, and the androgen.
I see a lot of PCOS.
Oh yeah, that's right. So we'll talk about PCOS because your androgens are going to be off with that, and with the fasting insulin will be off with PCOS. Okay.
Yeah.
So let's talk about fasting insulin, because this is a blood test that is not commonly ordered, I find. Everybody wants to be like, did you fast? And we'll take your glucose. That's like totally different than your fasting insulin. So can you talk about the fasting insulin blood test and what that shows us and what you would consider maybe normal or abnormal? Or
Yeah. So fasting insulin, what we're looking for is insulin resistance. And so usually I kind of start off by saying, okay, there's a spectrum. We're not suspecting, say you have diabetes, but it is on the diabetes spectrum. So like on one extreme end, you have somebody who's a completely normal person. And on the opposite end of the spectrum, you have someone who is a uncontrolled diabetes on injectable insulin therapy. But it's like not an all or nothing. You have diabetes on oral meds, you have pre-diabetes, you have insulin resistance, and then there's normal. So your insulin's going to be abnormal before your blood sugar is abnormal. When they're looking for pre-diabetes, diabetes, they'll look at your glucose, your blood sugar. We're looking for the insulin, that'll be abnormal first. So insulin is a hormone in the body produced by the pancreas that helps get glucose out of the bloodstream and into the cells. So when, say, you're eating a lot of sugar, or due to genetic things, your body just has a lot of sugar more in its bloodstream, your insulin has to increase its levels to get that blood sugar out of the bloodstream, because there's just so much glucose, and it gets into the cells so that the cells can use it to produce energy. So a lot of times with insulin resistance, for whatever reason, you have you're needing to get so much blood sugar out of the blood into the cells that your cells are like, whoa, too much. We're going to be resistant to the insulin, so they're not bombarded by the glucose. Works great for a time, but your glucose is still in the bloodstream, and so you have to produce more and more insulin to get it out.
And then you become diabetic.
Yes, further down the road if you don't do anything about it.
Yeah, so the insulin resistance is a really deep problem in our society, and most people don't know that they experience that. I think, in my opinion, we should be doing the fasting insulin blood work throughout the lifespan to find out where we're at, because I really believe that some of these problems go back to youth and your teens and your 20s. And we do know with intrauterine, she's saying, we do know with diabetes, you probably have had, once you're diagnosed with diabetes, you probably have had problems for a couple of decades. And we also know for women, once you're hitting about your 40s, your estrogen levels are going to go down in perimenopause as you're approaching menopause. The average age of menopause is 52. Well, as your estrogen levels go down, your insulin resistance naturally goes up, because the insulin needs the estrogen to be able to work. So if you have less estrogen, you are struggling with insulin resistance, which is part of my counsel to some of my women who are in their 40s, who are saying to me, like, I've gained 8 pounds and I haven't changed a thing. I'm still eating the same that I always was. Well, your whole physiology is changing. That's why you're gaining. And you might not be able to eat the way you used to be able to eat. You may need to exercise differently as well. So
great book for women in their 40s.
Okay, hold it closer to the thing. The Hormone Repair Manual. Maybe some of you already have this. This is a hot book, really popular.
I don't know if you can see it's screen's backwards, but yes, by Laura Bryden.
Yeah, that's well known. It's kind of a thick tome. It will give you tons of information about what you can do to improve your cycle. So the insulin resistance is a key thing. And let's go into, with insulin resistance, you do not have to have PCOS to have insulin resistance, but people who have PCOS do have insulin resistance, right?
Almost always. They don't have to, but most of them do.
Okay. So, but also you can have insulin resistance and not have PCOS. You just have it, you're chugging along, you think you're all good, but you're not. So let's speak a little bit about PCOS, because we did have a question on that, which was, this person submitted that she would like to hear what you have to say about PCOS and ovarian cysts, because she does experience both. So what are your comments on that?
So PCOS in general, high androgens in the body, testosterone, DHEA, DHEAS. It may or may not be, also have extrafollicular cysts in the ovaries. It's not required for diagnosis, but a lot of people with PCOS do have them.
Okay. You may develop the facial hair because you have these androgens.
Yes, acne, facial. Facial hair.
And you have to be watching how much carbs and sugar you're eating.
Yes.
Because of the insulin resistance.
So high androgens in the body encourages high insulin. High insulin in the body encourages high androgens. It gets to be this vicious cycle. So if you have insulin resistance, you're more likely to develop PCOS and vice versa. So getting the androgens under control, getting the insulin resistance under control can just calm everything down and help get rid of the facial hair and the acne and the inability to lose weight and all the extra abdominal fat.
Right. And you can, with lifestyle and good quality, high quality, working with a great practitioner like Sarah, you can reverse PCOS, right? Yep. I have plenty of friends who had PCOS who now have kids, who it was not a fun journey for them. They did everything I did. Lifestyle, they had to do something different because that is not something that I had, but you're on the same path of healthier living and different lifestyle. So that is hopeful. With those ovarian cysts that somebody develops with PCOS, is there anything that they should be watching for? Or, I mean, the severe sharp pain, do they need to go to the ER and see if it burst? Or
I guess it really depends if it's mean, if they're just seeing like all the little tiny follicular cysts in the ovary and they're just kind of hanging out, usually just treat the androgens and the abnormal hormones. It should resolve itself. If there are other types of cysts, I guess it depends what kind of cyst it is and where it is and how big it is.
Okay.
Anytime you do have that sudden severe sharp pain, you should get that checked out right away.
Yeah, we don't like sharp
I
pain.
know, yeah.
Shifting gears a little bit, unless there was something else you had to say about that hormone panel.
The only thing I was thinking about with PCOS is there are definitely some PCOS people who are thin. And so, and it can definitely have a genetic component. If your maternal grandma had PCOS, it can be passed down intrauterine. So you could have like the healthiest diet, lifestyle, still have irregular long cycles. Irregular and long cycles with heavy bleeding are very characteristic of PCOS. Also thyroid and insulin resistance. But you could have like the healthiest lifestyle, and I've seen it, and like, so don't rule it out simply because you're a normal body weight and you eat healthy. Like if there's still issues with your period, it's not normal. It's still helpful to check it out.
So again, that goes back to what we can do at home. You need to do your charting, and then you come to your provider and say, I have all of this. What can we do? And you would want to do this full panel because you need to look for any of these problems. And for PCOS, it would be the androgen problems and the insulin resistance, predominantly in the thyroid, are the things that might be the trifecta that would come up in the blood work. And if somebody were doing lifestyle and changes of lifestyle to improve PCOS or any of these irregularities, when would the next time be that you would generally advise rechecking this panel?
Usually I do a focused recheck of the abnormals in 3 months. And then in like, depending on how bad, like maybe in 6 months. Do a full recheck. Yeah. And if you're doing these lifestyle things, you probably won't see a full change in your periods for 3 months. So even though the FSH in the brain stimulates this egg to grow in this cycle, that egg started its initial development 3 months ago. So any changes you make to your lifestyle now is going to actually be reflected in your period 3+ months down the road. So if you've been doing it for a month, you don't see any period changes, don't get
no biggie.
Don't get fed up and quit.
In other words, if you were to become pregnant, that baby inside you was starting to develop 3 months before you got pregnant. And for the fertility enhancing program that I completed, it was completely based upon the ovarian maturation cycle. So we were on a 90-day program, and you kind of string it together, hoping that each chunk of 3 months you're experiencing meaningful benefits. That for me, I did. Okay, I have a question here. Somebody asked, what are the causes for an irregularly occurring cycle?
So hormone-wise, prolactin, thyroid, insulin, PCOS, main ones. Really anything that either your body's struggling to ovulate, so that first follicular phase is like drawn out as your body tries to ovulate, and then maybe it finally does. And then you have the luteal phase, but that'll cause a longer cycle, or it's an anovulatory cycle where your body is just not ovulating due to some underlying condition. And it doesn't have to be hormones. It could be like fibroids or things like that.
So let's talk a little bit about anovulatory cycles. That means that the A is in front of the word ovulatory. So anovulatory means that you did not ovulate, and you still may have a period, or maybe your period's a long time coming in between. So can we talk a little bit about women who may not be ovulating effectively? What are the signs of that? What are the risks to their health for that? Anything you wanted to comment on? What can they do to improve it?
So to improve it, figure out what's causing it and fix that. And we kind of touched on some of the causes. What it looks like, it could be a little different. It's usually very irregular when you do bleed. typically lighter, not always. It depends how much estrogen's building up the
Okay.
uterine lining before it sheds. Yeah, just too long, too short,
Okay.
too much or too little bleeding,
Yep.
very irregular, unpredictable.
And if I can give a suggestion for anyone who might be struggling with wondering if you are ovulating, taking your temperature really helps, because you can look and be like, that was way too short. I didn't really like rise effectively. And then there's also the things that you measure your ovulation with your urine.
Yes,
Yeah, so can
LH
you,
test strips.
yeah, I did those for a long time, but when I did them, it was different. You had to go to the bathroom at the same time every day and pee on it. And I was at
Yeah.
work and my time was 10 a.m. and I'd be in the middle of patients and like, just a minute. I
Yeah.
gotta go to the bathroom and take care of some private business.
Yep, it's kind of one of those piano stick things still.
Mhm. Oh, it is. Okay.
And you can get them pretty cheap on Amazon, those test strips. Usually recommend when you start noticing some like more slippery, clear mucus, then start measuring your LH. You'll see a positive result about 12 to 36 hours before you actually ovulate. That's when the LH spikes. They usually recommend not doing first morning urine for that, just because it could be more concentrated, give a false positive potentially. But you also do take lifestyle into consideration. If that's the only time you can do it at home or manage to do it, then sure. But if you get a positive every morning, then switch it up a little. Some people do it at night. It's more diluted, but that's the only time they can do it, and that works too.
I found that a little bit frustrating to use if you're going through some infertility, because sometimes you're peeing on that thing every day. You're waiting and then you're like, is there a faint line? Is there not? Have I ovulated? Did I not? But when you put it together with your charting of your temperature, you kind of know. So because the test strips, when I was doing it, that was expensive. So you would want to really time when you were peeing on the stick so that you only have to use it maybe for 3 to 5, maybe 7 days. But if you never get a positive, you just keep using it and using it.
I think, I'm ballparking. It was a while ago when I looked on Amazon, but you could get packs like 50 or 100 for like $15.
Oh, it's so much cheaper now. Remember, my kids are in high school, so my information comes from a while ago. Okay, that was helpful about an irregular cycle. There was somebody who asked, is there a natural way to regulate the occurrence of your cycle? For sure, there is. So let's go into some of these lifestyle factors that you've touched on, because it is going to be the lifestyle factors. Those are the main thing that you can hit, and you have to hit those hard. That's the program that I did. And I already lived really healthy. I'm this physical therapist who's all sporty and clean eating, and I upped my game, and makes a huge difference. So talk about what somebody can do to try to regulate their cycle naturally so that they're not doing it with medication that is not actually causing them to ovulate, and medication that they don't want to be on.
Right. So the basics that everyone thinks of: diet, exercise, sleep, stress. So with diet, cutting out the sugar, cutting out if you can the caffeine, any processed carbs like processed flours, cut out. Some women do need a certain amount of carbs, so like healthy, like a sweet potato or a brown rice can be a good way to do that. Dairy can be very inflammatory for a lot of people, so cutting out your dairy products, especially the straight up milk. I know a lot of women who say, okay, I can cut out the milk, but the cheese. Cheese is a big one, hard one to cut out, but can make a big difference. Yeah,
get rid of that cheese, ladies.
Yes, it's very hard. Speaking from personal experience.
Yeah, I know it's delicious, but
let's see, exercise. Usually recommend exercising 5 days a week, working your way up. Don't expect to run a marathon on week 1. Try and find something that you can enjoy, just moving, whether it's Zumba on YouTube in your living room, or going on a walk, a bike ride, pushing the kids in a stroller, something like that. Something you enjoy that will help you continue to do it. I do encourage green exercise, so doing it outside just helps the mental health too.
That's huge.
Yeah.
Okay. And I'll add to the exercise. If you have insulin resistance, you need to lift weights. Period. You have to lift weights. You've got to get stronger. The muscles are what are going to soak up all that extra glucose, and you need more muscles to reduce your insulin resistance. So that's one thing to add. And this outdoor exercise that Sarah's talking about is just so helpful. It's really peaceful, and there is strong data to suggest if you are working out outdoors, and if we can find, we have so much beauty here in Michigan, but if you can find a beautiful place to go for a run or a walk or do your lunge walks or do your HIIT training, you will likely get more out of that for your mind and your body than if you were doing the same thing indoor. And that is spoken from someone who goes to the gym. But I do walk. I walk my dog also. I mean, I love being outside, but I'm like a gym person too. Okay, so diet, exercise. Let's talk about the sleep. That's crucial. And when our hormones are off, our sleep is screwed up, and it's just this vicious cycle. So can you speak a little bit to what you would recommend for sleep for us and anyone who's having sleep troubles, maybe if they're at all, if they're under stress or if they're going through perimenopause? I have patients talking to me about sleep being a problem. What are your thoughts on sleep?
So a lot of sleep, let's see. I mean, you should, of course, aim for a consistent bedtime, a consistent wake up time. I usually tell people to aim for at least 8 hours. Some people can function on 7. Some people really need 9 or more. You should wake up feeling energized. Now, sometimes if you have sick kids or a newborn or whatever reason, sleep is hard. You work third shifts. Like, you just kind of have to work with what life throws at you. But consistency is key. Waking up kind of with the sun helps a lot of people, like going to bed at 3 a.m. and waking up at 2 p.m. every day. Like, that kind of consistency isn't as optimal because you're not working with like your body's natural circadian rhythm with the sun.
There's evidence that if you go outside, like wake up and get yourself outside, even for 10 minutes, no sunglasses, so that the sunlight can hit the back of your retina, that helps calibrate your circadian rhythm. Okay, so
no screens.
Yeah, no screens, and no screens in your bedroom. Your bed should only be for, the primary thing in your bed is sleep. If you're watching television to try to fall asleep, those are all bad habits, or your telephone in the bed. None of that would be recommended.
Right.
Okay, so there's some sleep stuff. Then let's talk about stress. You had talked earlier about the DHEA hormone that is coming out of the adrenals. That is a sign of stress, right?
Yeah.
Is that it? Okay. So stress is crucial for our hormone regulation, and we often aren't aware of the effects of stress on ourselves. And I think we're speaking to physical stress, mental stress, emotional stress, spiritual stress, medical stress, if you're going through medical things that are very difficult for you or your family, relationship stress. Stress comes packaged in all forms. For us moms, we worry about our kids, and that's a stress. If you're just always in the back of your head, this is the child I'm going to be worrying about, that's a level of continual stress. So if you're speaking about, and stress can hit our adrenals that shoot up our cortisol, and then we end up having all sorts of other hormonal problems. So if you're talking about stress, what is your viewpoint in terms of how to navigate it in today's world?
Yeah. So, I mean, some stress you can't modify, but and some that you can. Learning to say no is a big thing. Prioritizing sleep so that you have the energy to deal more effectively with stress, and just trying to sit back and take a good look at your life and being like, okay, what do I have to do? What do I just really need to cut out, and kind of what are the gray areas, and kind of work through in your life how you can reduce it. It's going to look different for everybody. Taking breaks of time is something I recommend, like during the day, taking 1 or 2 just 10-minute breaks to go to your car and close your eyes if you're at work, or if you're at home, just laying on your bed, closing your eyes, or just like reading a good book. Like, do something for 10 minutes that's just resting. It's a really great reset.
Breathing.
Yes.
I would recommend adding breathing in those 10 minutes. The deep breathing or diaphragmatic breathing is known to improve your parasympathetic nervous system engagement. Sympathetic nervous system is your stressed out one, and they're like a teeter-totter. So if you're stressed out, you got low parasympathetic. Simply breathing helps bring the parasympathetic, which is the vagus nerve, brings it up. And we, in our physical therapy, one of the modalities that we use is heart rate variability training, where we can measure and help your heart rate variability to improve, which is a reflection of how much parasympathetic nervous system you have going on.
Yeah, we sometimes give patients like a little handout at our office about vagal nerve stimulation. So improving the vagal nerve and parasympathetics, like things like colder showers and deep breathing and going upside down and different things like that. Humming.
Humming is huge.
Yeah.
It really helps the vagal nerve. So when you're outdoor exercising, get going like, whatever's fun for you, make some sounds. It really helps stimulate it because the vagus nerve comes out here, and you can rub your cheeks for it. You can rub your ears for it. You can rub this part of your throat, like the sides here for it. That helps stimulate vagus nerve. There's a lot you can do. Okay.
And there's
Yep.
supplements too, but I honestly think nothing beats cutting out the stress. So like helping the vagal nerve and everything is wonderful. But
okay, what supplements do you suggest for the stress stuff?
like ashwagandha, rhodiola, magnesium. I love magnesium.
Yeah, so let's talk about magnesium because the literature shows that 2/3 of Americans are deficient in magnesium, and it's an essential thing that we need to get essentially from our diet. And if we're not consuming it, that's a problem. And if we're going through a particularly stressful time, you're going to be burning through your magnesium reserves, if you even had any. And 300 reactions in the human body require magnesium to happen. So if you are deficient in magnesium, you're really going to have troubles. And because magnesium is like a relaxant inside your body, it helps your digestion, it helps migraines, it helps heart rate. If your heart is skipping beats, there's just a ton. So let's hear your perspective on magnesium and its importance, maybe with even hormones or this whole cycle.
It's a great hormone balancer, just overall helps with stress and sleep, and just it helps with the insulin resistance, and it just balances so many things. It can help your androgen. Like, I love it.
Is there a form you like?
I like magnesium glycinate or gluconate, unless people have problems with constipation. Then I love magnesium oxide or citrate.
Yeah.
Usually I say like 400, 500 milligrams a night.
Mm-hmm. Yep.
So
same here.
Okay.
Yep. Glycinate is my number one. But if you can't find glycinate at the grocery or at the health food store or something like that, pick up what you can. There's the brand Calm, which is a powder magnesium that you can put into your water and drink it before bed if you're somebody in particular who has trouble sleeping. But yeah, just get that in you. Usually I suggest, if possible, take it twice a day. So if you're saying 400 to 500 a day, so if you could break it up, that may possibly be advantageous, but I have, let's be realistic. Some people just don't remember. They want to get it all done in the morning, which is me. I pretty much just like, if I remember to take them, they're going to be in the morning. And
I take mine right before night. It's calming, and I just have it at night and at my little spot. Yeah. Sometimes if you're craving chocolate, that means you're magnesium deficient. Most people are magnesium deficient anyway, but I find for me, the more I crave chocolate, the more magnesium deficient I am. And then if I up my supplement intake, increase the chocolate cravings.
Is there a way to measure magnesium deficiency? I mean, they're measuring it when they found out 2/3 of American are low, but I don't think there's like blood work that's commonly done. No,
it's mostly magnesium is kind of housed in the cells, not in the bloodstream. So your blood work will probably show that it's normal, even if it's deficient in the cells. So I don't usually measure it.
I see. Okay. Now we did have a question. Somebody was asking about how to balance hormones if they experience chronic pain. We see individuals and treat people with chronic pain every day. I mean, endometriosis, interstitial cystitis, chronic tailbone pain, chronic pubic pain, chronic anus pain, chronic pain with intimacy. So, and there are a lot of hormone receptors in your private tissues down there, tons of hormone receptors, but it's more than just those tissues down there. It's your whole system is upregulated when you have chronic pain. So let's hear your take on how to balance the hormones for chronic pain. And
So a lot of people have chronic pain in general. Usually your pain increases around the perimenopausal time when your progesterone is going down and your estrogen's skyrocketing and then plummeting. So, and then you hear your take on it too, but like a lot of times if you don't have that progesterone to balance the estrogen, you do seem to be in a little bit more pain. If that seems to be what the question is asking, more from like the hormonal perspective. So if you don't ovulate, you don't make progesterone to counteract estrogen. Estrogen is great. You need it. It's very vital for you, but it can really ramp things up, and progesterone is just very calming. It can calm down the pain. It can calm down some muscle tension. It can calm down your mind. So sometimes people who have anxiety, getting frequent ovulation to get the progesterone to calm down the mind can help. And so, yeah, just progesterone can be very, make sure you're ovulating and getting progesterone. If you're in perimenopausal, maybe some people need like a little progesterone supplementation just to get them through a little bit longer.
How would they take progesterone? Suppository, oral, what is there?
When I prescribe it, I do a capsule that can take in either orally or vaginally. There's also creams you can do. The Hormone Repair Manual actually discusses how to dose a topical progesterone cream, and it has some brand recommendations in there as well.
I did some of that when I was in my thing, but it wasn't prescribed. It was, I mean, I had a provider suggesting I do it, but it was over the counter, and what was it made out of yams? And I rubbed it in or something. I don't know what
I don't
it
remember
was.
exactly what it's made out of, but it's, yeah, it works. It works well. It's a little harder to, dose the same amount every time because it's more of a cream, but
okay. Though that was helpful. Now you brought one of your books that we really like. We use this all the time, and then Sarah walked in with it. So it's called Explain Pain. I don't know if you've had the chance to see this book. It's maybe you could get it out of the library if you might be interested, if you do have chronic pain. The authors of this book have studied how the pain manifests in the body. And if you have pain, chronic pelvic pain, that pain is not isolated just to the pelvis, because the pelvis is communicating and you are experiencing the pain through your spinal cord and your brain. So the whole system is involved in generating that pain. And this book, Explain Pain, gives you a really great readable way of understanding it. It's made for the layperson to understand it, and it's written by pain science experts. And one of the authors, I am particularly fond of his work, and I've flown all over the country 3 times to see him speak and go to his continuing education courses, because he's an excellent speaker, and he's published for years on chronic pain and pain neuroscience. So if you're somebody who's watching this who experiences chronic pain, I know it's the pits. I'm telling you, you can improve with some of these lifestyle changes that she's talking about with hormones. That person's question was specifically how to balance hormones if you have chronic pain. And the answer that Sarah gave earlier about the nutrition, the exercise, the sleep, and the stress, those are going to be key components of you getting out of chronic pain. And if we're going back to the nutrition, it can be hard to hear, but you got to get rid of the sugar. You have to get rid of the inflammatory foods. She mentioned dairy as an issue, caffeine as an issue for a lot of us. And you have to know your body, know your gut, know what you can tolerate, and be strict with yourself for a period of time and see if you can feel better. Okay, anything else on that?
You just asked about the causes of low progesterone.
Okay, yeah, good question.
Any hormonal imbalance that would cause you to not ovulate, you would have low progesterone, because if you don't ovulate, you don't make that corpus luteum, which secretes the progesterone into your body. Other times when you have more naturally occurring low progesterone is puberty, when your body's just getting going with all the cycling, and the perimenopausal into menopause time, where your progesterone is slowly decreasing. After having a baby, your progesterone's pretty low. All your hormones are pretty low.
Yes.
But usually it's something that's causing you to not ovulate.
Okay. So we would go back to, if you have low progesterone, to get that full panel of blood work that she was talking about earlier, and you charting your cycle at home, and then you implementing these lifestyle factors, and you can make a difference for yourself. There's so much that you could do.
And this book, which is by the same author as the Hormone Repair Manual, it's our period repair manual. I love this book and recommend it to almost everyone. It'll talk a lot about just the different hormonal issues as well, which can cause low progesterone, go into a lot more detail than we can cover here right now, and also give you some good like supplement recommendations in addition to lifestyle.
Yeah, that book's excellent. I want to just quickly touch on somebody's question was that their period ranges from 31 to 46 days apart, and every healthcare provider she's seen has said that this is normal. Okay, I just wanted to repeat that. We covered earlier tonight that 21 to 35 days would be normal, and your normal needs to be hitting within plus or minus 2 days of your normal. So 31 to 46 days is a 15-day spread. That is not normal just right there, and that's long. That person who asked that question, you can get it better. Please don't feel defeated. There's so much you can do to turn this around with the information we're sharing tonight.
Yeah. And actually, I probably should make a little caveat. There is, if you have an abnormal cycle, once here, once there, up to 2 or 3 times a year, that deviates from your normal, like say you normally have this beautiful 29-day cycle. You ovulate in the middle, but you miss a month due to something that's super stressful. And then it continues on normal. That's fine.
Okay, that's helpful. Yeah, when you're under a super duper stressful time, give yourself some grace and be like, that was weird. That was a weird month, but now we need to get it back under control.
Yeah.
Okay. Somebody asked, and we're running out of time, so we're going to go a little more quickly with some of these questions, but somebody asked, they want to start trying to have children, to get pregnant next year, and they don't know how that's going to affect their, I guess, their hormones, their body, maybe some of the things that they should be doing this year. So what would you say to that? I'm sure you're working with patients all the time who are like, oh, I think next year, what do you recommend, Sarah?
Yeah, all the lifestyle things.
Yeah, huge.
I'm wondering if that was connected to this one.
Oh, okay, yeah.
Yeah, about the irregular far apart
Okay,
cycles.
Yeah. It's possible that person is the irregular far apart cycles.
So it could make it harder to get pregnant. Like say, so if it's that irregular, if you're not ovulating, you can't get pregnant. So you might be ovulating sometimes, but not other times. If there is PCOS, insulin resistance, optimizing your health, the lifestyle things, magnesium, different things like that, that would give you the best shot at both getting pregnant and having the healthiest pregnancy possible to help, your future children have the healthiest lives possible as well.
Oh, that's helpful. Okay, so one of the things that we mentioned earlier, if this person or any of you listening who have extra long cycles and you're thinking about wanting to become pregnant, get yourself educated, and I would say buy those luteal hormone strips that you're peeing on, like I talked to you about, to see if you can find yourself ovulating and measure your temperature and make the lifestyle changes. Do all that. Make an appointment with a different provider. For this person who was told that 31 to 46 days apart is normal, we disagree and think that you do need to see a different provider. You could see Sarah Yskes, and your practice is called Holy Family.
Holy Family Healthcare, yes.
And right now, Sarah is on maternity leave.
Yeah.
So if you want to see her, probably call her office and get on her schedule, because I'm sure it's going to be slammed when you do go back.
It will be. We have a midwife working with us as well. Her name is Hallie. She's great. So she works part-time. We both work part-time. I think she works Tuesdays and Thursdays, same as me.
Okay, so that would be another resource within her office. Somebody was asking about balancing their hormones after having a hysterectomy and keeping their ovaries intact. I treat many patients who have that experience. And so they are not positive if they're still ovulating or they're not. And maybe this person was asking about that. Do you have a suggestion for them?
Balancing hormones naturally do the same lifestyle supplement things as everybody else. If you're wondering if you're still ovulating, like say someone could order a pelvic ultrasound to see what your ovaries look like, or we could do some blood work to measure your FSH and your estrogen levels just to kind of see where those are at. Like if you're around the menopausal age, I'm guessing.
Okay.
Some people can still feel their PMS symptoms.
Yeah.
And they're like, oh, yeah,
That's
if I
true.
had a uterus, I would be bleeding in 2 days. So they still can, they can
They
tell.
see that? My other suggestion, I have this little piece of technology. It's here, this ring. This is a computer. It's called the Oura ring, O-U-R-A. And that ring measures your heart rate variability and your body temperature while you sleep. And it measures your sleep and the phases of sleep. And it can be helpful for someone with this situation. It's not the complete answer that you're looking for, but it's a helpful piece of data. So if you've had a hysterectomy, but you still have your ovaries and you want to know if maybe you're ovulating, this sucker will give you that temperature graph. So you can see like, oh, I had 15 days and then my temperature went up. You likely ovulated, likely, not definitively, but you likely ovulated. And it's a helpful data point to have that you might consider. Okay. We talked about that. Oh, there was a question in the chat about raw milk. You mentioned excluding dairy, but what are your thoughts on raw milk?
I haven't really looked or seen any research on it necessarily, but I do tend to think that the less processed it is, the better it is for you. I know cow's milk isn't really the same proportions of like your fats and everything that human milk is. Cow's milk wasn't really made for human consumption. So if like you're having issues, I would cut it out completely and see how you do.
The program I was in was, you are not allowed to have dairy, not even raw. So if Sarah's answer is correct, like, okay, maybe you can get by with the raw and see how that affects you. But if you are really interested in improving your fertility now, I would say go cold turkey on all of it, not even goat cheese and goat milk type stuff, although that would be more beneficial, more tolerated on this type of a program, or more allowed than that. Yeah.
Most people I know go to like a coconut milk or almond milk
or
something that's no sugar.
Yeah. Well, this was so helpful to have Sarah here. We covered the bulk of all of these questions here. Well, one last question. Somebody said that they rarely experience a menstrual cycle. Their last cycle was in February. So now we're at March, April, May. We've gone 3 months. And that person only got that cycle in February because she was given Provera. And she's wondering about her issues of low progesterone and irregular cycles. I think we've covered this, but what would you say to this person?
That you should definitely figure out what's going on to cause your no cycles. Because even if you don't want to get pregnant, like not ovulating means you're not producing the progesterone that's not helping balance so many things in your body and not optimizing your hormones, like something's off. Provera is not bioidentical to the progesterone that your body makes. But in some people can like stimulate a withdrawal bleed. So not a true period, but like a withdrawal bleed from the hormones. Yeah, I would get that checked out.
And one last point I want to make, you need estrogen for your cardiac health. For us women, the #1 cause of our death is a heart attack, and you need that estrogen. You also need it for your bone density. So I know when you're young and you're thinking like, my bones are strong. I hope I don't get osteoporosis when I'm older. I have treated many people in their 20s, 30s, and 40s who have osteoporosis today. You have to you need your hormones optimized for your overall health. The estrogen helps your skin so you don't have as many wrinkles. It helps I told you those hormones are in all of your private tissues of your perineum and your vagina and your vulva, your vestibule. You need those hormones in that area to have healthy tissue. If you're experiencing painful intimacy, that possibly is a sign that there's a hormone problem, although there's a lot of muscle things that contribute to that we treat. If you're not experiencing the right level of progesterone, you can also have troubles with anxiety. There's just so many things that go on. And then all of these hormone imbalances affect our mood. We just don't feel like ourselves. You're not happy and joyful. Things aren't easygoing. Everything can be hard to focus. So if you're experiencing this, please do yourself a favor, take your health into your own hands and implement some of these lifestyle factors that Sarah has called out. Get the period repair manual or get the other book, the menstrual cycle, hormone repair manual.
40 plus.
Start tracking your cycle and see where it gets you, because there's so much that you can do to improve your overall health. And if you're anybody who's watching this that's struggling with infertility, I want to give you another hug and let you know you can improve that circumstance. It can improve. You can turn this around. You need an excellent provider to do that with you and figure out what the natural ways are to do that, because your body can respond to the positive goodness that you give it and see where that might be able to take you. That's it. Okay. Yep. Please reach out to Sarah at Holy Family Health. In the chat, there is a link to her healthcare company, and it is
holyfamilyhealthcare.org.
There we go.
Yeah. And if you need our main number, it's maternity leave. 269-621-0011.
Look at that.
Yeah, you should be able to schedule online, but it's still sort of new software for us. So sometimes, just in case there are issues, then you can call.
Okay, that's helpful. So this has been an awesome talk with Sarah Yskes, nurse practitioner. I want to spell her last name. Her first name is Sarah. Yskes is spelled Yskes. She's from Holy Family Health, and she's really shared her time and expertise with us. I so appreciate it. This was one of our most popular talks. The other one that was really, all of them have been popular, but we also had an excellent response with the counselor that we interviewed regarding anxiety and depression. And I really think these hormones and anxiety and depression, they go together. So ladies, let's take care of ourselves and do what we can with these lifestyle factors. Reach out to Sarah or her team or your own team and get this proper panel done. Tomorrow, find out what your fasting insulin is. Thanks, everybody. I will send you the recording tomorrow also. We really appreciate all of you joining us. Good night.
Bye.
Thank you. Good night.